Welcome to the HERHealth podcast, transforming health for women and girls at risk, where we empower women and girls to take charge of their health and well-being. Join us as we shine a spotlight on issues affecting women and girls' health and explore ways to create positive change. Get ready to be inspired and empowered as we discuss health, advocacy, and empowerment for women and girls at risk. Please be advised that this podcast may cover sensitive topics such as gendered violence. We understand that these discussions can be difficult to listen to. If you feel uncomfortable or need support, we encourage you to prioritize your well-being. Consider exploring our other podcasts if these topics are triggering for you. Resources can be found in the description.
Hi, good day, everyone. Welcome to the HERHealth podcast. I'm your host, Alexandria Lazochuk, a community health science student at the University of Calgary. And today we're joined by Dr. Lynn Hagg, a CHR postdoctoral fellow and contract faculty member with the Faculty of Social Work at Wilfrid Laurier University. Dr. Hagg's research is focused on women survivors of intimate partner violence related brain injury, a field she approaches with both rigorous scholarship and a deep personal commitment, including her own lived experience of brain injury. And today's conversation builds on her webinar, Helping the Helpers, Recognizing and Responding to Brain Injury from Intimate Partner Violence. Many survivors of intimate partner violence may also be living with ongoing challenges from brain injury. The hidden public health crisis affects countless people, yet remains largely unrecognized. And today we explore what this might look like in practice and how helpers across health, social services, and community settings can better respond. Thank you so much for joining me today. I truly appreciate it.
Thank you so much for having me, Alexandria. I'm really grateful to have the opportunity to just share information and raise awareness and education on this.
Absolutely. So I got a chance to see a full webinar about IPV-BI, but could you help others understand what intimate partner violence related brain injury actually means, and how does it differ from brain injuries that we more commonly hear, like sports concussions or car accidents?
So we've known for a long time that people get injuries to their brains from sporting events or car accidents. And I think realistically, brain injuries from an exposure to intimate partner violence, to those physical assaults that can often take place during intimate partner violence, that's been happening just as much. It's just that we didn't know about it, and we didn't think about it in a way. So there's really a growing awareness around it. But what happens is we know that 92% of all encounters of physical intimate partner violence will include hits to the head, face, and neck, and or strangulation. And it's that really high proportion of events that are happening to the head, face, and neck. We know that the most likely sort of injury, once you think about bruises or broken bones, contusions, cuts, and abrasions to the skin, the most likely injury that's going to take place is one to the brain itself. So we're actually seeing quite a high prevalence rate. There are lots of different statistics in the literature, but I think most of us in this field would settle down quite happily saying that somewhere around 1 in 8 Canadian women are experiencing potential brain injury as a result of exposure to physical intimate partner violence. And that by and large, for the most part, to date, that's gone unrecognized, untreated, and unsupported. And so I think one of the big differences between what we see for folks who are experiencing brain injury as a result of car accidents or sporting injury versus the IPV group is that the other folks have access to recognition, to diagnosis, to treatment, to social supports, to disability supports in a way that survivors of intimate partner violence to date really have not. And so it's a particularly complex little problem that raises unique circumstances. We feel in the brain injury field, we feel that this is a particular subgroup of brain injury survivors that is unique, that requires specialized understanding, specialized resources, and targeted supports.
Thank you so much for diving in about what it looks like and how this is a as you mentioned, a unique circumstance to take more of a microscopic lens at. And I really did appreciate you taking the time during your webinar to explain the spread of statistics coming about IPV-related brain injuries, particularly since there are so many differences in the methodology and the location of the research, and being cautious that this is a new field, and we don't have the exact number yet, but we can kind of pinpoint that a lot of individuals are being impacted by a potential TBI. So thank you so much for talking more about that. And yeah, so the people would assume, kind of bouncing off of that question, that a brain injury must involve a fall or an explicit blow to the head of some sort. And your webinar added strangulation to this list. So I'm curious, can you highlight strangulation as a cause of brain injury? And can you walk us through why strangulation is so dangerous from a brain injury perspective? And clarify what makes it different from a traumatic brain injury or TBI.
Wow, that's a lot of question in one. So you're going to have to remind me when I forget. The
Yes.
first thing I want to say is what a great setup for me to dispel one of the common myths about brain injury, and that is that you do not need to have a hit to the head, face, or neck. There does not need to be a direct blow. So you can fall and fall on a patch of ice on the sidewalk, not hit your head, and that can cause a concussive injury. In intimate partner violence, we see injuries happening from people who are being shaken or thrown violently across a room and not actually a direct blow to the head. So I think it's really important to just clarify that. And I'm really glad that you mentioned that. In terms of the strangulation, it's a different type of brain injury than the traumatic injury, which is that jolt or that blow to the head. The hypoxic ischemic brain injury, it's called, and it's what happens when you cut off blood supply to or oxygen to the brain. So if you imagine somebody putting their hands or something else around somebody's throat and tightening that grip, it's cutting off both oxygen and blood supplies. So we see a very distinct injury. It can happen very quickly, much faster than the sort of thing that we would expect to see from a blow. It does look a little bit different on scans, and it does have some unique characteristics in the way that it presents post-injury that we don't see in a traumatic brain injury. But for the most part, they look similar enough and they behave similarly enough that we just talk about brain injury as a whole. We make the distinction that the two different types occur, and then we just talk about brain injury related to intimate partner violence. The one caveat that I think is actually quite important that people know about that is that there is a risk of lethality. So one of the things that can happen is you could have damage done artery, to the artery in the neck, and that could cause a slow bleed to take place. You could have blood clots happening as a result. So there are medical challenges with strangulation that really can have significant permanent. I mean, people can die from that, and not just instantaneously. So these things can happen for a longer period of time after the event than one might think. It's really important that we get medical care for people who have experienced strangulation as quickly as possible. And one of the things that we're talking about amongst us in the research field is this sort of language around choking and strangling. So I talk about strangulation because I think it's really important to see it that way. But lots of people in this field, in this sector, talk about choking. And that even extends to what people are talking about as consensual choking and engaging in an activity as part of consensual physical intimacy with another person. And I think it's really important that we raise awareness around this relationship between that action and potential permanent brain damage. And I think people don't recognize that that's a piece of that puzzle, and they need to understand that this is very real. It happens very, very quickly. It requires extremely limited pressure, the same amount of pressure that you use to open a can of pop. When you pop the tab on a can of pop, that's all it takes. Same amount of pressure that it takes to brain injure someone by choking or strangulation.
Wow, thank you so much for first dispelling my stereotype about brain injuries as a whole. I really appreciate it. Just to get more of a clarification about that, but then also kind of talking about the real impact that strangulation has and why sometimes the terminology across the field might not account for everything, and having that more language that's more specific is really important to highlight. I really do appreciate it. Getting
It
further,
also
yeah, go ahead.
it also really matters when we talk to the people that we're trying to support. So we know in the research that if we ask a survivor, were you ever strangled? You get a very high percentage says no.
Mm,
If you ask them, have you ever been choked? You start to get a higher percentage. If you ask them if anybody's ever done anything where to their neck or their throat where they couldn't breathe or they started to see stars or felt confused or they lost consciousness, you get a much higher rate of response. So how we frame our language and how we use our language is so important.
yeah, I feel like it'd be really important to get information to everyone that's impacted, not just researchers and academics, but
Yeah.
to the general public of the importance of both what does consensual choking mean in a consensual sexual relationship, but then also if what does it go too far. I think that'd be really important to talk to the public as a whole. And
Yeah.
kind of
What
looking forward.
starts as consent can change very quickly.
Exactly. And a lot of people don't know that they can remove. I think that having more of these conversations, just removing consent can be removed at any point during a
Mhm.
sexual relation and doesn't have to be at the very start or the very end. It can happen throughout. So having that is really important and knowing that is really empowering for individuals. I'll move forward to a really interesting part. So you mentioned in your webinar that IPV-BI could be an invisible injury, and which might make it difficult for people to see the impact of an intimate partner violence brain injury. And looking at research, including findings from your PhD work, is that poor mental health is strongly linked to both brain injury and intimate partner violence, and people affected are at risk of both anxiety, depression, and PTSD, a lot of mental health conversations, and these overlap and can be rather complex to tease apart. And in your presentation, you did a great example of the comorbidity of TBI and PTSD and how anxiety and depression can also fall into that. Sorry, I'm just rambling. And then also your API toolkit also has this if anyone wants to know more. So my question for you is, what are some typical signs and symptoms of IPV-BI that helpers should be watching for? And are these symptoms that are commonly mistaken as mental health challenges, and just kind of debunking that?
So it's really hard, as you point out, it's really hard to tease them apart. And it's really difficult to know, okay, so is somebody experiencing depression because of a chemical imbalance in the brain? Their brain has been injured and is now functioning differently on a chemical level. And so you've got that surfaces as clinical depression. Are they experiencing depression because of exposure to a traumatic event where their partner caused these injuries? Are they experiencing depression because life is really unpleasant and there doesn't seem to be much hope moving forward and they don't have any independence and somebody is trying to control them and that person tells them that they're useless and stupid and not valuable every single day. So you can see really, really quickly how all of those different things could be the underlying cause of what we see as depression. And so teasing those apart that's really difficult to do. And I'm not sure that we're going to be very successful at it, to be honest. I think there are pieces to remember. And one is look for the markers that are only going to be one or the other. So look for those indicators that tell you that a brain injury is a piece of the puzzle, whether or not it's the whole puzzle. You may never be able to tell that, but it's certainly a piece of the puzzle. And then look for those pieces where, what are those pieces of the puzzle that only belong to PTSD? That if you've got somebody experiencing flashbacks and nightmares, that's a PTSD piece. And so what is that? How is that relationship wise? How's that relating to the brain injury? And what's going on? What's the underlying, what piece of that puzzle is interfering with the brain injury piece? And I think the important thing, once you've figured that out, once you know that you do have all of these pieces, and let me just say that in this particular population, I expect survivors to have both. There's you've been brain injured by the person that you love that claims to love you, you're going to have both pieces of the puzzle at play. And so once you identify that, you can start to make sure that you are offering effective treatment and support concurrently and supporting both of those two pieces of the puzzle moving forward so that you see less of the negative interaction between them and more of the sort of everything unfolding and being able to be supported effectively moving forward. And I think that's the sort of the key message is know that you have both at play, recognize where both are coming to the table and identifying strategies that work to support both of those different pieces of the puzzle. If we only ever treat as a mental health condition, we're going to miss the physiological components of brain injury that are undermining the success of the mental health treatment. And what happens is they don't recover. So the longer that you treat somebody and they don't recover, the more likely it is that they take on a sense of ownership. I can't get better because I haven't done something right. When in fact, they're not getting better because we didn't support them adequately. So it's really, that's that piece about recognition that's so important and it makes a difference. If we can offer the right supports at the right time, we have way better chances of getting positive outcome.
Thank you so much for diving into that. I think it feeds so beautifully into a conversation that you're talking about in your webinar about different trajectories. You specifically mentioned frontline workers and how specifically paramedics, if they get on a call for a domestic violence incident, they might make a snap judgment and miss a brain injury um, piece of the puzzle. And that leads to different trajectories for an individual to not receive medical care for the specific injury they may have. So I really appreciate you diving into that as well. And then that also kind of brought up some conversations we've had like 2 years ago in our webinar series and our podcast series with Rory A. Marshall, a paramedic, and his struggles of trying to figure out how to get training on intimate violence calls or domestic violence calls and the barriers and facilitators as a frontline worker. So I see that these conversations are always happening, and I'm really glad to have this specific piece to discuss with you today. And this leads into the next question I had for you is that without specialized medical equipment, how can frontline workers like paramedics or shelter workers or social workers realistically begin to recognize that a survivor may be living with a brain injury? And are there tools or protocols that might make this possible for them?
So I love that you asked me this question because like I honestly I feel all the time I'm just the bearer of bad news. I have nothing but depressing news on any level when it comes to this intersection, except on things that we can do and things that we know that we can support in this group and how we can recognize it. Um, there has been a lot of confusion to date on how do we recognize it, what screening tools are available, what's the right one to use, how do we go about asking questions. And one of the things that our team is working on now, we've spent about a decade asking these questions and thinking about this. So we've put a lot of thought behind it. And one of the things that we're doing right now is we're developing new recognition and response toolkits that are going to be context specific. Because one of the big challenges is if you're a paramedic, the way in which you're screening is very different than if you're a frontline worker in a shelter or if you're in the justice system and your client you're a lawyer trying to figure out what is going on with your client. But everybody needs to understand all the different pieces of the puzzle. So what we want to do is develop a much simpler tool to screen. We really only want to ask three questions. One, did an event take place of some sort that could have caused an injury to the brain? So you're looking for those hits to the head, face, and neck, and you're looking for strangulation. Did any of those things occur at some point that could have caused this problem? Your second question is looking at what are the symptoms? Are you experiencing any of this huge long list of symptoms like the one that we put up in the webinar? Easy to get your hands on a copy of that. If you need a copy of those symptoms, go to the ABI toolkit, go to the SOAR website, go to the Canadian Center for Intimate Partner Violence and Brain Injury. All of us have lists of these on one pagers, a nice, clean, easy infographic for you. You can tack it up anywhere in your office. So you want to know, that's your second question. Are any of those symptoms present at the time immediately after the injury? And your third question is just, it depends on your context a little bit. You probably don't even need it in all contexts, But in some, you want to know, is anything still happening? So, what were the immediate symptoms post injury and what are the persistent symptoms? Are you still having challenges with any of those things today? And how long ago was the event? Once you know those three things, if you've got yeses to those questions and if you've got two or three symptoms from the brain injury and you've got an event that took place, absolutely it's a possibility. And at that point, it's better to move forward with a medical professional who can appropriately assess and diagnose. We're not asking for paramedics and police officers and frontline workers in the gender-based violence sector to diagnose. We're asking you to recognize what's happening and respond appropriately. And response is about two things. It's about, are your services accessible to your client on a disability level? And if not, how do you shift those? And who do I refer to next? Who's the person down the pipeline in that systems of care framework? What's the next best step for this person? Where can they receive appropriate care? And that's about building your parachute. That's about knowing what services are available in your community, who to reach out to, whose name and number do you have on your desk that you can pick up the phone and say, this is the person sitting across from me. This is what they're experiencing. I think maybe we have something more complex here and I need your help. And I don't know if that answered all of your questions.
It did, definitely. I truly appreciate more of those concrete protocols that individuals in those different fields or contexts can understand. Like, hey, these are the steps to take. Who are individuals that are going to make this an accessible space for them, but also have the right tools in their toolkit to best provide the best support for the individual experiencing a IPV-BI brain injury. And
So
yeah,
I'm just going to add one little last piece. We don't have the new recognition and response toolkits ready right in this moment. That's the piece of work we're working on next. So we're hoping to have those, I would say, late summer or early fall of 2026 we're in. So they're coming soon.
very quick. It's going to blink. It's going to be September in this field. Yeah, so let's say a helper suspects a brain injury. Someone comes in, there's this implications of memory might be a little bit off, their organization skills aren't up to par. What does meaningful accommodation look like in a practice, and what are some concrete adjustments that can make to better support survivors?
So this is another piece of really good news. People in occupational therapy and physical therapy and vocational rehab, they've been working with folks with brain injuries for decades, and they're really good at supporting people with brain injuries with exactly these kinds of cognitive challenges. Those challenges and those interventions don't change just because the injury happened through intimate partner violence instead of a car accident. We can still make use of that information and those techniques. It's just that they didn't know that they had all these folks with brain injuries either, because this has just been the best kept secret in women's healthcare for decades. So I think, again, it comes back to the cross-pollination piece. It comes back to knowing who you can talk to in your community, knowing who the occupational therapists are or the rehab therapists, who's the local PT who knows about brain injury, who works with people with brain injuries, talking to your hospital service providers, talking to your family doctor providers, learning who it is who can help implement those kinds of basic interventions. And they really are basic. In many cases, it's about memory aids. It's about planning and understanding how much energy you have in the day and recognizing what are the things that become bigger barriers than they would for other people. How difficult is it for you to remember when you go to the grocery store to do the grocery shopping? How difficult is it for you to remember what you needed at home? How many challenges do you have in doing your day-to-day job? And what are the things that can happen to change that? And they really can be small and manageable and inexpensive. It's just a question of recognizing what the problem is. It's not that somebody doesn't want to make your appointment over and over and over. It's that they don't remember. Calendars are huge. Accommodation tricks and tools, day planners, sticky notes. Like it really can be that basic. So I think that's the good news, is that there is a lot we can do to support survivors of brain injury, no matter how they got the injury. what has to happen is that we need to recognize that that's what it is. It's not a behavioral choice to be difficult. It's not somebody who can't be bothered to remember appointments or who's not invested in their own self care. It's someone who's prevented from it because of a physical limitation that we did not see.
So beautifully said. Thank you so much for emphasizing that. And I think that gives a lot, or at least for me, just knowing that building these networks with people like our OTs, rehab therapists that have done all these interventions for a very long time, just through a different lens, is just a wonderful thing to just have in the back of your toolkit or just to have a number if when and if you see those symptoms or those signs. So I appreciate you diving into that.
The piece of that's equally important, that's the flip side, is that our brain injury guys were never trained in trauma informed care. They didn't
Mhm.
know that they were going to have to serve this huge population that has this piece of the puzzle along with it. So they need your help from an IPV gender based violence sector. They need help just as much as you need their help to understand brain injury. They need your help to understand trauma. That's the beauty of this cross pollination approach, is that you each have incredible vats of knowledge. It's a question of sharing it with a group that didn't know they needed it. And once we've got that and we move forward with that level of understanding and awareness, that's when we really start to have parachutes that are going to make a difference.
Definitely. I agree with you 100%. Shifting just a little bit, in the beginning of your presentation, you did a wonderful explanation of like what prevents individuals from leaving an IP situation. You didn't
Mhm.
blame the individual for their circumstance, which I feel like in this field, no one does anymore, but I know that some people, particularly like my friends or family, might have that misconception still. So thank you for empowering that. You also mentioned that items like fear or financial impacts or love or these cognitive impacts make it difficult for an individual to leave an IPV situation or just a very toxic situation. So, kind of focusing on that like, cognitive impacts, my question for you is that survivors often interact with legal or child protective systems while living with an unrecognized brain injury, which does affect their memory, their communication, and ability to follow safety plans, not because they don't want to, because it's just really difficult for them to. How does unrecognized IPV-BI put survivors at risk within these systems, and what should helpers advocate for?
Puts them at a lot of risk. So, folks with disabilities still experience a lot of stigma. Being diagnosed with a brain injury is not a bonus in that sense. As someone who's lived with a brain injury for 24 years, I can tell you it's it's not it's not a get out of jail free card in that sense. And yet um it does need it does have an implication. It changes how we parent. It doesn't mean we can't parent. Nobody ever asked me, was I capable of parenting with a brain injury because I'd received one in a car accident? But people are constantly being, women who have been brain injured by an intimate partner, their capacity to parent is now called into question in a family law court. It's an unbalanced unfairness that you really can't sort of quite understand how that's even happening. Just because somebody was injured by their partner, that now makes them less of less capable of parenting it. I mean, that doesn't make a lot of sense to me, but it's what we're seeing.
Mm.
So that risk is there in the court system. Um, if it's undiagnosed and unrecognized, it's even a bigger risk because of those assumptions around when we see communication that doesn't fit with the patterns that we expect, or we see behavior that doesn't fit what we would expect people to do. In this context, we tend to think it's a choice. We think that this is something that the person is doing. They're either manipulating or they're lying or they're trying to get out of something or they're trying to throw blame at somebody else. They're not taking responsibility, all those pieces of the puzzle. And none of them are good. None of them are going to put the survivor in a favorable light. That that entire situation is just so much more likely when nobody understands that the brain injury is at play. The minute I've seen so many frontline workers who sit back with this knowledge coming at them for the first time, and they have two reactions. Their first reaction is to say, how can I have worked in this field for all these years, decades, and we missed this? How could we have missed this? If only I had known. And their second reaction is it changes their physical, they physically shift in front of you, and you see them give up the idea that they were being disrespected, that they were, that their client was disinterested, that this was somebody who they couldn't invest their professional care into because the client couldn't invest in themselves. So they were going to shift their focus and put it with someone who would at least benefit from their services. And they actually physically shift, and you can see the change happen, and they start thinking, well, wait a minute, if that's not their fault, if that's something that's happened to them that's part of their experience, then how can I change that? How can I support them? And they go back to being that helping professional, and they want to address the challenges and get to the bottom of the problem. And it just shifts the way that they see their client, and it shifts the way that they interact with their client. The same thing's going to happen in the court system. If judges and lawyers understand, if juries understand what they're seeing and why, it changes the way that you interact with it, and it changes how you judge it.
Thank you so much for first highlighting that stigma exists in both undiagnosed and diagnosed brain injuries, particularly in this IPV field, and that just the contrast that it just doesn't seem fair for victims or survivors of intimate partner violence to be placed with that stigma that can negatively impact when navigating both the law system or child protective services. And I really appreciate you very firmly highlighting that, but as well as just like that example of that helping professionals getting to see that change, reevaluating and like contextualizing that person's lived experience and understanding, oh, maybe what I'm doing right now isn't working best for them, but these are things that I can do now knowing this context or having more of an open lens. I really appreciate you stating that.
This is why we talk about it as a public health concern, because this is a disability related issue. And this, to me, this is the only time that we are punishing women for being a different, for having different abilities. And I mean, I know there are lots of ways in which those of us who are differently abled have all kinds of barriers and challenges and all those pieces, but we're not actually, generally speaking, we're not being actively punished for our disability in a way that survivors of intimate partner violence brain injury are at high risk of. And I think until we switch and we see this as a public health concern, as a medical problem as a result of exposure to violence, that's when we can change this.
That feeds so perfectly into my next question because you mentioned that, but also that many provinces now, that New Brunswick is like mentioning that IPV femicide is an epidemic. That this webinar is funded through the Public Health Agency of Canada, or what we like to call PHAC, and is designed to build consistent awareness across all sectors. And in your view, what are the biggest gaps now that you're seeing in terms of like this research, policy, or practice, whichever you think is more salient to you?
So I'm located in Ontario, and we recently declared intimate partner violence as endemic. We addressed this question of whether or not it should be declared epidemic, and the decision in the end was to declare it endemic, which actually I think there's been a lot of reaction to that. That's sort of, negative. Oh, they sidestepped it kind of thing. And actually, I think in many ways it's more realistic. It is endemic. It is rooted in our society in a way that we can't just create an antibiotic and fix this. And that's what people think about when they think about epidemics. Um, so I think in many ways the choice of language was not inappropriate. I'm pleased that Ontario has stepped forward and has made a statement like this. We now have a public policy document that clearly states that this is a situation. I think every single province that follows this or has led this and has equal statement, it's excellent. I very much would like to see a national approach. The work that we do, we launched the Canadian Centre for Intimate Partner Violence and Brain Injury It's Canadian, it's national for a reason. That standardized approach, that one stop place where you can go and get the best information on whatever the topic is. I think that's important. I think, yes, we have idiosyncrasies in our provinces. I've actually been in nearly every province in this country or territory at this point. Yes, we are unique. There are so many individual subunits of Canada, but ultimately we are a nation. And I think if we move collectively forward, we are stronger. We can address this challenge, and we can hope for some success, not only in treating intimate partner violence brain injury, but in eradicating or reducing the prevalence rates of partner violence at all.
Thank you so much for diving in. As someone from Alberta right now, I think that message is more clear than ever for contextual reasons, but I truly appreciate you kind of defining endemic and how it's different from epidemic, but also just like the cross-national approach is going to be the best in both solving, not, I don't want to say solving, but addressing intimate partner
Yeah.
violence, but and related brain injury as well. Thank you so much for diving into that.
I don't know that we have, I don't think we have a fix. I don't think I have a solution. What I tell people in workshops that I do these days is, you know, the more we talk about it, the more we understand it, the more we are compassionate to folks experiencing it from both sides, the more we support people involved in violent relationships, whether they're the ones throwing the punches or they're on the receiving end, the better chance we have of changing the history here. And the history is, it's getting exponentially worse. The COVID certainly increased the rates of intimate partner violence. It increased the severity of the attacks. We know that it has not receded. Um, this is not a problem that we can afford to ignore, and we can't afford to just leave it quietly, hidden away in people's houses anymore. We need to talk about it. We need to do what we can. Maybe this isn't going to solve everything, but it's better than doing nothing. And I'm a firm believer in, I mean, I'm a social worker. So at the end of the day, I'm always going to look for those strengths. And I think we have a lot of strengths in our communities. We have a lot of folks who've done a lot of work in these fields. It's really about connecting everybody together and working together in an approach to address these challenges. And that's about understanding all of those unique pieces, right? That's about understanding the challenges that are experienced in Nunavut versus in Toronto versus in Alberta. Right? They're very different. Those are very different contexts. They're very different experiences. There are cultural implications. There are all sorts of inequities that have to be addressed and understood. But I think we're on that path. And for me, that's what this is all about.
And I really appreciate the movers and shakers to these conversations. And everyone has their own little niche, of course, for their PhD. You do this massive amount of work in a specific area, but it's so important to highlight that work and to share with as many people as you can because we can learn so much from each other. So thank you for highlighting that aspect as well. And kind of leading to the last question is like, if for someone listening today who may work in healthcare, social systems, education, or just community in general, what is really important thing that you want to tell them or to walk away with? And where can they access your tools and resources?
So the number one thing I want you to understand is that intimate partner violence causes brain injuries. And we know this, and we know it's the same prevalence rate as breast cancer in this country. It is ridiculously high. Once you understand that intersection even exists, please do what you can to get educated, to increase your awareness, how to recognize it, how to respond to it, what to do in your community. How do you help a survivor? And the way to do that, as you point out, Alexandra, is to go and get that information. Here in Canada, we now have the Canadian Centre for Intimate Partner Violence Brain Injury. We're at www.IPV-BI.ca. The SOAR project has been doing great work out in British Columbia for the last decade. They have some great resources, as well as the Abused and Brain Injured Toolkit, which is the ABI that's out of the University of Toronto, and the ABI Research Lab at the University of Toronto. All three of those spots have lots of information for you and ways for you to connect out into more specialized. If you're looking for sort of a deeper dive in just a tiny piece of it, we have ways for you to do that as well. So you can sort of skim the surface and get what you need, and 5 minutes later you can meet your client and feel like you have more confidence in your ability to assess the situation. Or you can spend a couple of days and do a deep dive and really learn about as much as I know on this subject, because we just put everything in there. So lots of different ways to do that. Folks can also find me at Wilfrid Laurier University in the Faculty of Social Work.
Thank you so much for joining me today, Dr. Hagg. I really appreciate having this conversation with you. I truly appreciate it.
Thank you very much for having me. I'm delighted to be able to share the information.
Thanks for joining us on the HERHealth podcast, transforming health for women and girls at risk. Remember, your health matters, and together we can make a difference. Until next time, remember to prioritize your health and well-being. For more resources and support on issues affecting girls, women, and gender-diverse people, visit our website at avatraining.ca. This is Dr. Nicole Letourneau. Thank you for listening.